Hello, everyone. Welcome to today's session on nursing's role in addressing racism. I want to thank you very much for joining us as we examine this important issue. My name is Shawn Kennedy, and as Editor-in-Chief of the American Journal of Nursing, I'll be your host for this webinar. This webinar is the fourth in a series of important issues affecting nursing practice and healthcare. Before we start and introduce our moderator and speakers, I have, of course, just a few general housekeeping items to review. First, everyone's lines have been muted to avoid background noise. And then within your presentation console, you'll see a various number of interactive little widgets at the bottom of the screen. And they all do various things. Use the Q&A tab if you're having any difficulties with technology or if you want to ask a question. We will set aside time at the end to take questions, and we'll answer as many as we can. So during the program, just keep typing in your questions and we'll get to them at the end. You'll also see a resource tab under which you can find a reference list. You'll also find information for how to obtain CE credit, as well as other information about AJN and other webinars and products that we'll be doing. There's also a subscribe today button. There's a special discount of 25% on subscriptions to AJN if you go through the webinar today. After the presentation, please take a moment to complete the survey so we know what worked and what perhaps didn't work with this webinar. Your feedback is invaluable as we plan future webinars. This webinar is being recorded. Several of you have asked that question already, and the link to the recording will automatically be sent to all of you via email at the end of the program. I'll just put up the CE information slide very quickly. It is accredited for continuing education credit for 1 contact hour. Again, you can get all this information in the tab, as I said at the end. We will also email you this information with the link to obtain CE information at the end of the webinar. We'll include a copy of these instructions in the follow-up emails with links to the meeting. So AJN, just a little bit about AJN. We have a long history of providing content nurses need to deliver high-quality, safe care. And that means covering more than just clinical nursing topics and includes raising awareness of key issues that impact the health and welfare of those to whom we provide care. Issues such as poverty, forced separation of families, as shown on this recent cover of AJN, gun violence, health inequities, social justice, and racism. These are all nursing topics. And our examination of these topics must include how we manage our own house. How are our practice and education settings exemplifying best practices and following our own code of ethics? We're extremely pleased today to be able to host this program on such a critical issue with such a distinguished panel. Today, our moderator, Dr. Kenya Beard, will put several questions to the panel, and you will hear from a lead responder, followed by the other panelists weighing in with their perspectives. We will take questions and comments for the panel at the end, so again, please submit them throughout the program. Our moderator today is Dr. Kenya Beard, the Dean of Nursing and Health Sciences at Nassau Community College, which is part of the State University of New York. As a 2012 Macy Faculty Scholar, she founded the Center for Multicultural Education and Health Disparities and propagated research and best practices to advance the needle on diversity, inclusion, and health equity. In her former role as Senior Fellow at the Center for Health Policy and Media Engagement at George Washington University School of Nursing, she wrote blogs and co-produced healthcare disparity segments for the Center's radio program HealthCetera on WBAI-FM for an audience of over 400,000 diverse listeners. Dr. Beard is a fellow of the American Academy of Nursing, the New York Academy of Medicine, and the Academy of Nursing Education. She is chair of the American Academy of Nursing's Diversity and Inclusivity Committee, and she's also a member of AJN's editorial board. In addition to myself and Kenya Beard, AJN's editorial board member, Karen Rausch, and our clinical director, Betsy Todd, were also involved in planning this program, and I thank them for that. And so today I'm grateful for these very distinguished individuals who have agreed to speak with us about this issue. Virginia Adams, is co-chair, Diversity and Inclusivity Committee at the American Academy of Nursing, and vice chair, New Hanover County Health and Human Services Board. Currently a nurse education program consultant, she was dean and professor, School of Nursing at the UNC Wilmington, among other academic posts. She was the inaugural chair of the core steering group of the International Council of Nurses Education Network. She also served as the first director of the inaugural NLN Center for Diversity and Global Initiatives, which developed a cool toolkit to increase diversity in nursing education programs. Her work as an education and community health advocate has been recognized from local organizations to international associations, and we're very happy that she's here with us. Dr. Sheldon Fields is founder and CEO of the SDF Group, LLC, which is a health innovation consultant company. He has 29 years of experience in the health sector as an educator, researcher, clinician, administrative consultant, health policy specialist, and entrepreneur. He's a well-known and respected HIV/AIDS prevention research scientist with a focus on young men of color. He is a lifetime member of the National Black Nurses Association and currently serves on the board of directors and chairs its Health Policy and Research Committee. He's the founding president of the Greater New York City chapter of NBNA. He's a fellow in the American Association of Nurse Practitioners, the National Academies of Practice, and the American Academy of Nursing. He's an advanced AIDS certified registered nurse and board certified family nurse practitioner, and we welcome Dr. Fields. Ann Kurth is a leader in higher education and health with a passion to improve the world. She's currently Dean and Lorimar Professor at the Yale University School of Nursing and Professor Epidemiology of Microbial Disease at Yale School of Public Health. Dr. Kurth is a fellow of the American Academy of Nursing and the National Academy of Medicine, for which she chairs its board on global health. She's past chair of the Consortium of Universities for Global Health, which is a 190-plus university member academic global health association, and has served on the U.S. Preventative Services Task Force. An epidemiologist and nurse midwife, Dr. Kurth's research focuses on HIV, reproductive health, and global health system strengthening. She has received numerous awards for her science and leadership, including Friends of the National Institute of Nursing Research Award and Sigma Theta Tau International Researcher Hall of Fame, and we welcome Dr. Ann Kurth. We also have, very pleased to have Dr. Bernadine Lacey, who began her nursing career in a segregated program in Mississippi and went on to become founding dean of the School of Nursing at Western Michigan University and an advisor to President Clinton. She's the recipient of numerous awards, including the Living Legend from the American Academy of Nursing in 2014, the R. Louise McMannel Medal from the Nursing Education Alumni Association of Teachers College, Columbia University, and the Legacy of Leadership Award from Howard University. And Dr. Lacey is joining us on the phone today. I would urge you also to read her history, an oral history in the August issue of AJN. It's a fascinating read and attest to Dr. Lacey's perseverance in pursuing such an illustrious career. Mary Maryland is a board-certified nurse practitioner with Oak Street Health in Chicago, a nurse practitioner for 20 years with a focus in primary care. She has worked extensively with adult, underserved, and at-risk populations. She has been a consultant on eliminating health disparities and racial bias and underrepresentation of minorities in nursing and the health professions. She's Dr. Maryland also participated with Human Resources for Health program to improve access to healthcare in Rwanda, Africa. And she's also served as a subcontractor with NASA. She has served on the boards of the American Cancer Society, the American Nurses Association, American Nurses Credentialing Center, and Secretary of the American Nurses Foundation. She was also president of the Illinois Nurses Association and the Illinois Division of the American Cancer Society. And we also have Dayna Bowen Matthew, who is Dean of the George Washington University Law School, a nationally recognized lawyer and legal scholar with over 3 decades of industry and academic experience. Dean Matthew is the first woman to lead GW Law. Yes. An expert in health equity and public health policy, Dean Matthew previously served as the University of Virginia Law School's William Matheson and Robin Morgenthau Distinguished Professor of Law, and the F. Palmer Weber Research Professor of Civil Liberties and Human Rights. She was also a professor of public health sciences at the UVA School of Medicine and served as director of the Equity Center at UVA. Prior to her tenure at UVA, she was a professor of law, vice dean, and associate dean of academic affairs at the University of Colorado Law School, and before that as professor of law and medicine at the University of Kentucky College of Law. Dean Matthew has held a number of positions in the policy world. She was a Robert Wood Johnson Health Policy Fellow for U.S. Senator Debbie Stabenow and a senior advisor in the Office of Civil Rights at the U.S. Environmental Protection Agency. She's also a non-resident fellow in the Center for Health Policy at the Brookings Institute. Among her many published works on healthcare reform, public health law, health disparities, and civil rights, she's the author of the book, Just Medicine, A Cure for Racial Inequality in American Healthcare. So this is who we are in terms of our distinguished, very distinguished panel. And we wanted to get a little bit of an idea about who you all are. So I would ask you to please complete the poll that we have in here that you see on the slide. Just say, tell who you are. I'm sorry we couldn't fit absolutely every category that nurses occupy or other people occupy, but please do your best to indicate what your position is. And we'll just take a minute to see the results. All right, so we have staff nurses, advanced practice nurse, nurse management, nursing students, almost 30, over a third nursing instructors, professors, some non-nurse healthcares, and then, of course, the other category as well. So that is a nice mix of people, and I know from looking at the attendee list, we have over 800 people who are here and over 2,000 who have pre-registered for this meeting and who can gain it on recording. So we're very happy that you all attended. Before I turn it over to Dr. Beard, just to review, this is what we want to accomplish today. We wanted to look at what actually is structural racism and how to define it. How do we recognize it in the many nursing settings that we operate in? And then what can we do about it? What specific actions and activities can we do to influence change? So at this point, I'd like to just turn it over to Kenya Beard.
So thank you everyone for joining us as we explore nursing's role in addressing racism. I want to first thank Editor-in-Chief Shawn Kennedy for spearheading this platform where forward-thinking leaders could come together to discuss racism, a word that for some has been subliminally silenced from our vocabulary, but nevertheless persistently operationalized. So what is racism? Dr. Martin Luther King Jr. defined racism as a false doctrine of the congenital inferiority and worthlessness of a people. This false belief has normalized and legitimized behaviors that have disadvantaged racialized groups. That worthlessness was made apparent when we witnessed the brutal murder of George Floyd. But does racism exist in healthcare? Do we consider anyone worthless? Healthcare providers, all of us on this call, espouse to be egalitarian, and we support health equity, the right for everyone to achieve their highest level of health. We work hard every day to deliver high-quality healthcare and to even prepare students to do the same. So why did the Institute of Medicine publish this bold and provocative report called Unequal Treatment? Congress asked the IOM to investigate the extent to which disparities existed. The IOM report illuminated that racial and ethnic minorities receive a lower quality of healthcare than whites. But how does this happen? Well, I recently lost my father-in-law to COVID, and when my brother-in-law called me to tell me that he couldn't breathe, I said, call 911. When 911 showed up, they didn't want to take him to the hospital. So my brother-in-law called me, and he put me on speakerphone, and I said, what is his pulse ox? What's his oxygen sat? and it was in the 80s. I said, he can't breathe. He's saying he's having a hard time breathing. He can't finish a sentence without taking a breath. And the O2 sat is low. How is that not respiratory distress? They realized that I was a healthcare provider and they took him to the hospital. A little over a month later, he died. How does this happen? In 2004, the IOM implicated bias, prejudice, and stereotyping as a few of the factors that could help explain healthcare disparities. This year, we have moved upstream and are calling out structural racism. So, Dayna, in your book, Just Medicine, A Cure for Racial Inequality in American Healthcare, you provide a socio-legal reflection that details the history of health disparities. So could you define what structural racism is and tell us to what extent healthcare, to what extent have the laws that mandated segregation in the past have actually influenced the healthcare policies and outcomes that exist today?
Thank you, Dr. Beard. I like the framing that you've given me for my question because it implicates law. Structural racism is a system. It goes beyond the individual bias. It goes beyond the individual preferences or prejudices. But it reflects those individual preferences, biases, and attitudes in a system of institutions that are organized by this thing we call race. So the institutions would include our governmental institutions, our educational institutions, our food, our healthcare and hospital institutions, our housing institutions. The point is that the system organizes two things according to race and racial hierarchy. Number one, opportunity. The resources to be healthy and to compete in our society are organized by these systems that are hierarchical. Number two, value. People are valued as less than or more than, and it's important, Dr. Beard, to understand that this is not done necessarily explicitly anymore. But historically, laws that segregated during the 1900s by housing, you might say, what do those segregation laws have to do with today? Well, they organize our housing system even today. So although they were established in 1910, 1915, 1920, if you bring forward the fact that during 1933, the Homeowners Loan Corporation organized who could buy a home in what neighborhoods by redlining. If you fast forward to the GI Bill, to the Hill-Burton Act, these are federal laws that organize who could borrow money in order to buy homes, who could borrow money to get education in non-segregated institutions. My point is this. Segregation that was established by law in the 1900s is still defining segregated opportunities today. Housing is the best example because today, much of our landscape is as segregated by race and income as it was in the 1900s.
So thank you for that explanation. And I heard you when you said the system, it's more than just bias, it's the system. But the bias reinforces this system. So does anybody else want to add to what Dayna has shared already about the systematic ways that structural racism has been allowed to persist?
Well, since you asked, I'm going to add one thing, if I may. I don't want to talk over someone who's next. If I may, I'll add one sentence.
No,
and then I'll quit. What we need to understand is that individual biases are reflected in our systems, which reinforce our individual biases. It is a circle of reinforcement. So if I am individually biased, then I might discriminate against you in rental housing, in teaching, in education. And once I do that, I come to expect that you and your group are not going to be as smart, as healthy, as compliant, as educated. And so the opportunity reinforces the system, which reinforces the opportunity. It's circular.
Okay, so this is a circular conversation that's going to get pretty deep in a second, because I want to go back and touch on that historical perspective that you already highlighted. So, Bernadine, your oral history interview published in the August edition of the AJN gives us a little snapshot of how you have personally experienced racism in nursing. Can you walk us through how structural racism shaped nursing prior to the Civil Rights Act of 1964?
Well, the school that I attended in Mississippi was they called it a segregated school. Segregated in that it admitted a select number of what was called then, I think we were colored then. My class was 8 colored nurses in a class of 64 white nurses. Now, the way it worked is that in the classroom, the 8 of us colored nurses were seated in the back of the room. The 64 white students were in the front of the room, and there was you'd always call it an invisible partition between the white nurses and the black nurses. I could not, even though my practice was at Mississippi Baptist Hospital, I could not walk through the front door of the hospital. Even though I was going there to do my clinical experience, I had to go around either to the back or the side of the hospital to enter. There was an annex to this hospital called the Green Annex. The Green Annex had been built to admit colored patients. The money for that was given by a family whose last name was Green, and they were responsible for the program admitting colored students. They said they would only give the money to the program if colored students were admitted. And so that this Green Annex housed colored patients. During my time at Baptist, it was a Guilfoyle School of Nursing, we did not practice on the colored unit. In other words, my clinical experience was always with the white patients. The only way that we had an opportunity to practice with the colored patients was we had 2 days off a week from school. And on one of those days, we all elected to work on the Green Annex. We were paid, however, as graduate nurses because we could only work on that annex when we entered our junior year. So junior and senior year, I could work there. I could not eat in the dining room. I had to eat in the kitchen of the hospital. So no amenities that were offered to the white nurses, they were not offered to the colored nurses. We had separate dormitories, if you call it a dormitory, so we did not live with the white students.
So it sounds like your access to education provided you with a very different experience than someone who was white. And I heard you when you said that money was given only to the institution if racialized groups were admitted. And I paused at that because we hear that language today in the form of grants, where $1 million grants are only given if there is some type of diversity language used inside the grant. So I'm going to ask, Virginia, you were the dean of UNC Wilmington, and I know you were a freshman when Kennedy was killed. So can you give us a perspective of, to what extent would you say that structural racism shaped nursing following the Civil Rights Act? Did we lose Virginia? No, Virginia, you're on mute. That's okay.
I think talking while you're on mute doesn't help. Okay, thank you very much. But following the Civil Rights Act of 1964, I think we would all like to believe that racial discrimination no longer exists, but it did persist, despite that the law said that legal segregation was ended. So what was written in the laws at that time didn't automatically influence our attitudes and the beliefs of the oppressors. The behaviors continued. Until that time, it was just like my colleague Bernadine talked about, the hospitals themselves were divided by color, and she was right. If you were in a large city, there was probably a Black hospital and a white hospital. I was educated in North Carolina. So in the Black hospitals, we had Black physicians. And actually before that, we had white physicians that were in charge at the Black hospitals. That was one form of segregation that continued after 1964. So even though the Title VI of the 1964 Civil Rights Act mandated integration of the hospitals, there were so many facilities that just refused to obey the law. And Alabama was one of the big ones that did that. And the others just used the paper rules to look like that they were complying with the law. So this is what happened to me. They dismantled the Black hospitals following the Civil Rights Act of 1964. So in that dismantling, some of the staff from these hospitals were hired at the white hospital, these facilities, but the positions that they had held, the leadership positions, were not offered to them. But Black nurses continued to play a significant role anyway, in terms of desegregating those hospitals, the nursing schools, and the nursing associations. When I was a student at Winston-Salem State University, my first clinical rotations were in the segregated hospitals. We did not have white students. There was a hospital, there was a Baptist hospital that had white students. We were not allowed to attend. We had the colored hospital, it was called, with old or non-existent equipment, and it was designated for Black patients only. The hospital that was designated for whites only did not allow Black students to practice. So my class and classes before me were forced to travel out of the state for our pediatric and OB experiences. Some of our classes went to Maryland, as far away as New York. But we ended up at Meharry Medical College in Nashville, Tennessee, and we were taught by Black physicians, Black nurses, Black educators, and it was a warm and nurturing experience. But it meant that we had to leave the state in order to find adequate clinical rotations. What happened after that was my senior year, we were actually a part of the forced integration of the hospitals. And that was not a pleasant experience. We were not welcome. We were not welcomed by the nurses, and sometimes the patients were hostile. So that was emotionally exhausting, but we had faculty that provided a lot of care, a lot of nurturing. And because we had had such a wonderful experience as we traveled to Nashville, Tennessee at Meharry Medical College, we were able to endure that kind of situation. But the law, the point is the law changed. Attitudes didn't change. Behaviors didn't change. Practices were definitely slow to change. So as a new nurse and working in a VA hospital, I was told by white male veterans that they wanted a real nurse, because obviously I could not be a real nurse. And on one occasion, one of those veterans said to me, he was introducing his friends, his visitors, and he introduced them and said to me, well, these are my buddies and they're from the Ku Klux Klan. I said, okay. And he was also saying at that time that my care was not appreciated. He wanted a real nurse. And at that particular time, I was the only RN on that shift, but I had a white LPN, so I gladly obliged and sent her to take care of him. So that was how the structures continued on after the Civil Rights Act of 1964.
So Bernadine and Virginia, I want to first thank you both for your tenacity and your courage. Truly, your stories should encourage all of us to do more and to do better. When I heard you say that the law changed, but the attitudes did not, in nursing, the one thing that is supposed to unite all of us, regardless of the language you speak, the color of your skin, our professional values must come first and foremost. Our values must speak out to the country. We have to demonstrate those values in our words and our thoughts and our actions, because nurses are different. People trust us because we do seek to deliver high quality care. But in Dayna's book, she talks about how we all have to have that self-reflection, the ability to reflect and ask ourselves, all of us ask ourselves those critical questions. What else can I do? So, Mary, you testified before a U.S. Congressional Committee on the need for healthcare reform. How can individual nurses recognize not just the need for reform, but the effect of structural racism in their practice settings and in their own practice?
Thank you so much. Yes. The testimony in relationship to the need for healthcare reform was really important in that it spoke to the value of understanding what it is that the public needs. In terms of our ability to address structural racism, and I'm pleased we have so many different disciplines represented, staff nursing, advanced practice, educators, and others. We have to take advantage of the opportunity to speak up and speak out. So we normally may not think of ourselves as advocates, but in this role, we can advocate on behalf of our patients. We can advocate on behalf of our institutions. We can advocate on behalf of what is right. So let's say, for example, in a hospital setting, we do have staff nurses. So there are those things that are evident in terms of policies and procedures, the things that you learn in orientation, how to request vacation. The things that may not be so evident is that there's a seniority process to getting vacation, that there's a process to getting tuition reimbursement. So it's being willing to ask the questions to get the answers that allow you to overcome whatever the bias is. Let's say in education, you're the newest faculty member. So obviously there are things that you do not know. So how do you find a mentor who can tell you, here's how to organize your syllabus, here's how to get your PowerPoints together, here's how you make an appointment to get technical assistance. So we have to be first aware of what we don't know, and then be aware of how to get the help that we need. So those things help us be proactive to make the environment work for ourselves.
So that's a great statement. We have to be proactive. I totally agree with that. But how could I be proactive if I don't see it? So what does it look like? What would I be proactive about?
So recognizing bias can be a little bit more difficult. It's usually a matter of something feels uncomfortable, something's not quite right. And so being willing to go with that, something's not right. Being able to ask the question, is this the way it's always done? Putting up your antenna, paying attention. How does it work for other people? And once you identify it, it involves some risk taking. You can't fix it on your own, so you have to have what we call allies. You have to have people who understand what the situation is and can give you guidance about how to move forward. So it is an initial feeling Bias is not always overt. It is not always something that is crystal clear, but something within you says, something's not right here. I need to understand how to navigate this environment. So the other piece is, let's take the example of a staff nurse again. If you are an excellent clinician and you are still having difficulty with meeting the needs of your patients, what is it that's missing? Is it that you don't know how to get resources for them? So once you identify that the problem is external to you, then you have to identify how to get the resources to meet the need.
Okay, great point. Sheldon, I know you shared also an example of what bias looks like. I think at the American Academy meeting last year, I heard you speak about an experience that you had with an instructor. Could you share that? And I know it put you on the spot, but could you share that story? Because it was such an aha moment for the audience that we were able to say, I get it.
Yeah. So thank you. You know, when I was a nursing student back in the late 80s, early 90s, my senior year of nursing school, in my very last clinical rotation, we were working on a unit, and we were working, you know, as senior students with your staff nurse mentor. And I had a patient who had came back from some type of surgery the night before. And one of the things that I had to do was to make sure that she was voiding post-op. So I went and I did her I's and O's, and, you know, you do your calculations. And I had noticed that this patient had not voided in quite a few hours since she had came back from surgery. So I went to present these facts along with the rest of the vital signs to the staff nurse. And she looked at me and she says, well, no, that's not a problem. You know, she just won't pee because you're a man. And right before I realized what I was saying, I said, you know, could we possibly think of any number of medically related clinical reasons why a post-op patient might not have voided, except for the fact that her male nursing student happens to have a penis? Now, I use a different word for that. But standing behind me, I then hear, Mr. Fields, we cannot behave that way. My nursing instructor was standing right behind me. And she immediately said, I need to talk with you. I was like, absolutely. But first, I need her to answer my question. And it was one of those aha moments for me that, and we wound up in the dean's office, you know, a day later, where the dean said to the nursing instructor, the student was right. Did the nurse actually answer his question? And what did you do to support him? And it was one of those things where I realized that as a male nurse, I was going to have some issues related to things that had nothing to do with me, but a perception of who I was as a person. So, you know, related to that, Kenya, we haven't, I would like to think that we have moved really a bit further along in this discussion, but I don't think we have. Because I talked with male nurses.
I want to stop you right there for a second, because I think we all need to pause and think about the stories that Bernadine shared and Virginia shared. Because clearly we can say we no longer have to sit in the back. We can sit in the front if we want to. We can say that we don't have to travel out of state. However, and I'm getting a lot of feedback, so if everybody could be on mute. We might not have to travel out of state, but we're not sure if we don't investigate who has to travel the furthest. We don't know, you know, what those statistics look like, because we probably aren't looking to see what they look like. But clearly we are not where we were 100 years ago or 50 years ago. But yes, to your point, we still have a long way to go to move forward. And that's why we're here today. So in your research, Sheldon, you've identified the emotional distress that occurs when some groups are mistreated in healthcare. Now, we know the emotional distress that Bernadine had to endure during nursing school and when she became a nurse. You know, it's outlined in that AJN article. We know Virginia as well had to endure a lot. And to this day, we are enduring, but not the same things that they have endured, but not to dismiss what's happening today. So because of your research, can you tell us what responsibility do we have as nurses in addressing the structural racism in our practice setting? Not just recognizing it, but now addressing it. Because like you so elegantly stated, you pushed back, right? When that nurse said, she probably can't urinate because you're a man and you're there, you said, what are the other reasons? And that kudos to you for being a young nursing student to speak up, because something horrible could have happened to that patient. Medical errors are the third leading cause of death. And some of those errors we found out are happening because people do not speak up. We have been conditioned because of the hierarchy and the being racialized not to say something when we see something. And at the end of the day, sometimes the patient dies as a result. So what are your thoughts on that?
So as members of the largest group of healthcare professionals and the most trusted profession overall, all nurses are part of a sacred social contract that we have with society. That contract comes with the responsibility to uphold all of the principles of the ANA's Code of Ethics, and thus obligates each of us to address issues of structural racism, not only in a practice setting, but in every aspect of our practice. Systems of structural racism only work by centering whiteness as the default norm, thus advantaging anything associated with whiteness, or i.e. white people, over anything associated with color, i.e. people of color. In a profession such as nursing that is 80% white, structural racism is ever present and playing out in a practice setting in many conscious and unconscious ways. Nursing prefers the Florence Nightingale angelic image, juxtaposed with the reality of its racial composition of the workforce. This has led the profession to struggle with the attempts to reconcile its lack of racial and gender diversity that makes it, in my opinion, impossible to fulfill its social contract. This leaves much work to do in the profession, and each individual must do their part if we are ever to make real progress in addressing structural racism. So specifically, if you take provision 6 of the Code of Ethics, that states that the nurse, through individual collective effort, establishes, maintains, and improves the ethical environment of the work setting and conditions of employment that are conducive to safe, quality health care. The code underscores how each individual nurse must be aware of their practice setting environment, the cultural norms, and the practices that they may be promoting structural racism. Only recognizing and structuring how the system is organized based on holidays celebrated by the white majority population is one way. Our example, operating with policies that continue a white status quo in hiring, promoting, and retaining nurses must be acknowledged, challenged, and changed. If you are sitting in a meeting with a completely homogeneous group of people, and you do not realize that this is an issue in a world that is much more racially diverse than you are, part of the problem, and no matter how comfortable this may make you, it also makes you complicit in the problem. Working with clinical protocols that continue to value the white majority standards of care without any acknowledgement of the need for cultural, competent, and appropriate care is to be derelict in your responsibility to improve the healthcare environment and make it safe for all of your patients. The second related code of ethics is provision 4. which also goes on to state that the nurse has the authority, accountability, and responsibility for nursing practice, makes decisions and takes action consistent with the obligation to promote health and to provide optimal care. This provision clearly underscores the individual issues of accountability and responsibility that each nurse has to their practice, their very judgments, decisions, and actions. If you witness issues of structural racism in your practice setting, you should feel empowered as a nurse and obligated through your code to address them in whatever level of the organization you find yourself. You have the authority to take action and to intervene, to speak up, and to advocate for those changes. Nursing must use its collective voice, and nursing does not use the power that it has to directly influence these issues of structural racism in all of the various settings, because it has a direct implication and an impact adversely on your work environment and the very quality of the care that you deliver. To not address the issues is to act unethically, and again, violates our social contract with society. We must be intentional in our actions if we are ever really able to combat structural racism. If you are not intentional, and if you are acting as a bystander, and if you are not currently having conversations within your nursing circles that are making you uncomfortable, then you are not having the type of conversations that are going to move our nursing profession forward. Thank you for the opportunity.
Sheldon, thank you so much. Well said. And thank you for making the connection between structural racism and our commitment as nurses, as the profession outlined in our code of ethics, that we're supposed to promote health and optimize care. And when the Institute of Medicine is saying that, you know what, we're not promoting health for everyone, that time and time again, these studies are supporting that people from racialized groups are receiving a lower quality of care. And, you know, when I thought about it and I did a lot of research and I said, well, you know, it's happening with adults. I was really surprised when I found the study out in California that looked at the whole state, the NICU units, and they found out that the neonates in intensive care units, the quality of care was different for those babies, depending on their race. That study came out from Stanford, and it amazes me that it's 2020 and we're still struggling with how we can get better. But to your point, Sheldon, it takes a courageous voice. It takes someone to be able to speak up and speak out against it. And I am so appreciative of the fact that we have Anne now, who Anne is on her Yale School of Nursing's website. She has explicitly called out racism and not only said that the School of Nursing would do more, but she shared a blueprint that has gone somewhat viral inside of nursing that amplifies how schools can move toward anti-racism. So when I think about the courage that Bernadine had to endure in nursing school, the insults, the slurs that weren't implicit, they were very explicit. When I think about what Virginia had to endure with patients telling her that they're from the KKK and the visceral response that must have had on her growing up in the Deep South. And then moving forward and hearing your conversation with a nursing clinical manager on the unit, and then having your dean reprimand, your instructor reprimand you, maybe perhaps because of the way you said it, but still not focusing on the patient. And fast forward, it's 2020. I'm sure we have nursing students on this call that they're a different generation. They don't want to repeat this. They don't want to have stories like Bernadine go in vain, or your story fall on deaf ears. And can you share for us, and I want to thank you for your courage, because you were one of the first schools to come out and use the term racism and talk about how you were going to move the needle closer to equity. So can you share how we can move toward a discourse that recognizes and dismantles structural racism in nursing education?
Thank you so much, Dr. Beer. This is a very inspiring, esteemed group. And I just want to note that the apology and the blueprint that we came up with at my school, it was really driven in very large part by student concerns and statements. We also have a council that is looking at these issues across the whole of our communities, and it's made up of faculty, staff, alumni, and student representation. And so we're trying to work on it cohesively, but it is clear that at this moment in time in America, hundreds of years in the making, looking at the terrible racial disparities in COVID mortality and the fight for against structural racism, we do have to get our house in order in nursing and midwifery. And that means in our schools as well. I think I'm echoing some of what was said, which is that the positive side of this is that we're 59% of the world's health workforce. We're 2% of the voting population in the United States. We should be able to leverage that for good to dismantle disparities. We do know, however, that we still have, we're still not walking the talk in terms of even our representation in schools of nursing. Our students reflect the diversity of our patient populations, our faculty much less so. And so we must have Black, Indigenous, and people of color faculty to speak to the lived experience of racism, but white faculty also have to interrogate white privilege, which is the flip side of racism. And so we do have to truly acknowledge our harms in order to address them. I'll just mention, I think we have to also think of this at several levels. One is certainly at the individual and school level. How are we doing holistic admissions? How is the curriculum really reflecting what racism is? Or do we just talk about racialized groups? How do we achieve success and equity for the different backgrounds that students come into nursing schools with? And we do have to take ownership, I think, again, for the white faculty. That means addressing white privilege and power, not shying away from it or retreating into white fragility when it's named. And Dr. LaRon Nelson, who's a wonderful faculty at our school, he gave a good analogy in a faculty meeting once. He said, you know, we never ask ourselves, are we capitalist? We live in a capitalist system. It's just understood that, yes, we participate in a capitalist system. And that's the analogy with racism. We live in a racist system. So getting to some degree of common language, though, in the way that we acknowledge, name, teach, address, I think is important. Some of us have touched already on the nursing acculturation issues. How often do we try to acculturate our students into sort of the hierarchy or chain of command versus really being more expansive? We have to recognize that faculty use heuristics and framing. We know from the Human Genome Project alone that race is not a scientific truth. It's this social construct that has terrible continuing negative power. But, you know, if you're an epidemiologist, you want to turn to that table 1. Population by race. If you're a clinician, you want to be able to say 45-year-old African-American, right? We go to these heuristics and we risk having these racist heuristics actually getting embedded even in our clinical algorithms. There was a recent piece in the New England Journal of Medicine about that, that racism itself is a predictor, not race. The Jackson Hart study recently published found that those who report lifetime discrimination have 2 times more likelihood of developing hypertension. That's the way you discuss racism when discussing hypertension. So I'll just mention that the Macy Foundation had a conference this spring on addressing bias in health professional education, and there will be a report coming out in a few weeks. And it recommends, one of the clear recommendations is to have anti-bias curriculum, including some core curriculum. So we are trying to move to that, and I think we need to make sure that thread carries through all the way to doctoral level, because that's where our faculty come from in the future. Second level is health systems. Remember, we're dependent on our preceptors to help educate our nursing workforce, and there's racism and bias in those systems and with preceptors. How do we work together to address that? Finally, the third level I'd say is thinking about in a structural way about credentialers, accreditation standards. Can we do more with that? Medicine's been talking about competency-based education for a longer time than we have in nursing. The remediation literature, how do we get all students to success in nursing schools is surprisingly sparse. So I think we need more research in that space. And I know NLN is starting to look about incorporating social determinants of health into curricular requirements. We can think about the AACN essentials, magnet status at hospitals, questions to ATI of what's in NCLEX, what's in NCLEX do. Are there racialized assumptions in the way some of those questions are framed? We mentioned the U.S. Preventive Services Task Force, which sets primary care and screening guidelines for the country. They produced an article just thinking about the issues around how might we screen for social determinants of health in the primary care setting. And I'll just close by saying, let's do more science so that we get to evidence-based approaches in our curriculum and that we share those tools widely. We don't keep sort of repeating and rediscovering the wheel. We urgently need this if we're going to have our schools, our clinical settings, and our broader society achieve that beloved community where risk of illness, death is not a privilege, or privilege is not determined by racism.
So,
Dr. Beard.
Wow.
Dr. Beard.
Thank you for that. Yes, Virginia, go ahead.
I'd like to sort of ask a question to piggyback on what Ann just talked about. There is this whole thing of racial gatekeeping in higher education, and it means that students who are the term qualified always comes up, that students are not qualified for admission. So there's the gatekeeping in student admissions, there's the gatekeeping in hiring faculty who come from different ethnic backgrounds, and that's usually controlled by, we're looking at predominantly white faculty because they are in control of the system, so they are the gatekeepers. How are you addressing that with your admissions committees, with your faculty hires and searches, that kind of thing?
Yes, no, thank you for that. And actually, just this last week, Yale is having to step forward with the Justice Department to stand up for holistic admissions, where racial group is one of the factors that's looked at, because that has been challenged now by the Justice Department, specifically at our university. So we've tried to move to holistic admissions. The point is, though, then when you have more people coming in, because we're talking about upstream issues, K through 12 education, terrible racial disparities in expenditure and support, right? So when you have more holistic admissions, how do we get to equity for everybody who may be coming from a variety of backgrounds, and support everyone to that success to the largest extent possible? And I think we've got to keep moving that forward, and also ensure that our faculty reflect the community. And I always say to this generation who, they won't have it. They're not going to sit still for some of the things that I think many of us, certainly white nurses, have sat still for too long. They won't. And they will someday be the faculty in charge and the administrators in charge, and they will certainly reflect, but we can't sit still till then either.
Right. And you also mentioned, Anne, the importance of anti-bias training. And again, it was brought up earlier, the laws and the policies can change, but if the attitudes do not, then you're going to get more of what you're getting, right? Because the laws and the policies can do so much. And the Civil Rights Act of 1964 has shown that. So when we move forward, Dayna, we're going to get you back in here. In order to move forward, we need to think about, on a systematic level, what actually needs to be done, and how do we respond to those who say that when we talk about structural racism, it's nothing more than propaganda. It doesn't exist.
What a privilege to be a part of this brilliant conversation. I want to say, if someone thinks it's propaganda, just look at the data that's coming out of the COVID-19 crisis. It is evidence of the structural racism and the structural inequality that we've been talking about. It is an example and exhibit one of what has been true historically and is true currently. If you go on the CDC's website and look at the age-adjusted deaths from COVID-19 and the hospitalization rates just from this month, what you see is that Native Americans, African Americans, and Latinx Americans are experiencing morbidity and mortality by multiple times greater than white Americans in this society today. Now, some people say that's because of underlying comorbidities, and what I want to do with my final comment is sound the alarm for the patients. Why do we need all the structural changes that the speakers, Dr. Maryland, Sheldon Fields, and Ann Kurth, and so many have referenced? Why do we need those changes in your profession? It is because nurses are different. It is because nurses hold the key to relationship, to patient advocacy. We need you to get your house in order so that the morbidity and mortality disparities that we are seeing in COVID, that events that patients of color, Black, Latinx, Native American, are experiencing discrimination in housing, discrimination in education, discrimination in criminal justice. Those structural inequalities are what are producing those underlying comorbidities. We need you to advocate for these patients and the structural racism that is killing them disproportionately today. When I worked at Senator Stabenow's office, that's what you heard in the introduction, I was really and truly a glorified clerk, but my job was to listen to those advocates who would come into her office and speak on behalf of patients or others. I can tell you without a doubt, when nurses, when health professionals, when clinicians showed in, she listened. We listened. You have the ear. The tradition of the medical committee during the civil rights movement should be fast forwarded to today. So when you are correcting your delivery, when you're diversifying your workforce, addressing your anti-biases, you are equipping yourself to become advocates on behalf of your patient population, and they need you. And if you hear nothing else from me today, it is that structural racism is real. It's being exhibited in the COVID data. It is not new, but it is urgent, and we need nurses to address it.
Thank you. And I think we're up for the challenge. And I see Sheldon's hand is up. Sheldon, go ahead.
So Ann, in particular, I want to push back a little bit because, I have been an academic for, LaRon was my student. That's how long I've been an academic. And we talk a lot, and nursing talks a good game about how we need to diversify our faculty. But, I was the first Black male faculty member ever at the University of Rochester. And after a certain amount of time at that school, I realized that I couldn't get promoted. I couldn't advance my career. So there is a lot of us out here who have hit what I'm calling the white female ceiling in nursing. Real talk.
Oh, I think is that my sound?
That as faculty, we are not being able to progress. Then, within the last decade, the RN population for African Americans has increased 1%. That tells me one thing very clearly. We are not letting Black students into nursing school. And that is really unfortunate because we will never mirror the percentages of African Americans and other people of color if we don't even admit people into nursing school to begin with. So you're a very powerful dean of a very important school. What would you say to your colleagues about one thing that they can really do to help move this needle?
Yeah, thank you. Dr. Fields, I agree with you. The pace has been just way too slow. And I think some of it has to be structural. So we have to look at the appointment and promotions criteria. Is anti-racism work embedded in what's rewarded for promotion and tenure, for example, on the faculty side? And that is something we're looking at and considering as we think about how we do faculty reviews, our annual reviews. So the admissions piece, I agree with you, holistic admissions should be the norm. It doesn't solve the whole problem, and we still do have underrepresentation in the RN population, and that is hugely problematic. I think there's also, frankly, let's be clear too about funding. You know, we spend $17 billion a year to train physicians in the United States. There's never been a GNE kind of graduate nursing education support, and I think there's also a resource question to this for African American students as well as nursing schools.
So indeed, there's a lot to be done. And if we're ever going to advance or increase the number of students who are coming from racialized groups, we're going to have to change the culture and the climate. And Dayna said it so elegantly. We've got to do this. It's like the world is looking at nursing, the most trusted profession. If we can't do it, then who do we think will or could? So yes, it's difficult. Yes, there's a lot of biases. We have to be honest with ourselves. We all have biases, right? That's how our brain is wired. We are wired to look at things and categorize things to make sense of the world. If you see a poodle versus a pit bull, your response will be different. But unfortunately, in this society, when you see a Black man, there are stereotypes baked in there that it allows your brain to see something different. So we saw how that difference in what you viewed could become a practice that allows a police officer to kill someone. We can see how in our country, no matter how hard we work to make sure that everyone receives high quality care, that the studies are still showing that if I go into the emergency room with chest pain and Ann goes into the emergency room with chest pain, chances are I will be treated less aggressively. And when I ask my colleagues, why would that happen? Too many of them don't know why. That's a problem. And it doesn't matter who you are when I say my colleagues. My colleague could be Sheldon. We all need to know why that happens. We all need to be able to self-reflect and ask ourselves, to what extent am I complicit with this bias? What do I need to do differently? There is a lot that can be done. Indeed, we've talked about a lot of things. We are no longer going to sit by idly as a profession. We see it happening across all of our organizations. But now is the time for us to come together. We can disagree, but we have to understand the differences. There's no more time to say, show me the evidence, show me proof that racism exists. If you don't see the proof, then you probably never will. So we'll have to leave you behind. And I don't want to leave any nurse behind, but I think about Colin's book, From Good to Great. And he says, we need to be on a bus going in the right direction. And that direction is health equity. And there are going to be some people who don't want to get on the bus, because when you get on the bus, we're going to have conversations about dismantling racism. And if you're consistently saying it doesn't exist, it's going to be very hard to move the bus forward. We can do it. Nursing does so much already. Our voice is so valued. And we see how the number of nurses are already in Congress, passing laws. But we have to be mindful that what was said earlier, laws do not change attitudes right away. To change attitudes, we need to create environments where people feel safe to speak up. And we need to learn how to speak up in a way that doesn't shame anyone or point fingers or blame anyone, because all of us are biased. Maybe today's not your day to say something that's biased, but if you can talk, you have said something that would have offended someone somewhere had they heard you. We have to keep that in mind. We have to stay humble. In nursing, for the most part, we are a very humble profession, sometimes to a fault. But if we're going to advance the needle on health equity and do what Dayna said we can do, achieve equity, and ensure that everyone has their ability to achieve a high level of health, then we're going to have to do this collectively and collaboratively. We're going to have to look to each other to understand the different realities that we all have. And don't argue those realities. Rather, try to understand the different experiences we've all had. I have a 21-year-old son. I should not be afraid when he goes for a jog because I've seen what happened to Ahmaud Arbery in a white neighborhood. That should not happen, but it does. So when I hear someone say still in 2020 that racism does not exist, my first question is, how are you defining racism? And then after we define the constructs, how do we move forward? We could do it. So without any further ado, I want to ask Shawn to come back and entertain questions from the audience. You've been great. Thank you for being here. I want to thank the panel for their voice. Indeed, we're going to help make a difference.
Thank you, Kenya. And I do want to just, before I go into questions, I know Mary Maryland has had her hand up, vigorously shaking it, so I wanted to give her a chance to say something.
Yes, thank you.
Thanks so much, Shawn. I think in this particular time in history, we must take advantage of the opportunity that's presented before us in less than 90 days. We have a major election. I hear comments that you cannot legislate certain things, but indeed without a legislative environment that's conducive to asking for what is right, we indeed are handicapped. In healthcare, health disparities don't happen by happenstance. They happen because of funding. Health disparities happen because there are resources that are not equally distributed. Let's not lose this particular moment in history and not take advantage of the electoral process, not just at the federal level, but every level. It impacts our lives. And as nurses, we certainly know firsthand what matters for patient care, what matters for access, and that those things can make a difference.
I want to underscore what Dr. Maryland has just said with an italics, with a bold, with a neon sign. Even though Dr. Beer is absolutely correct, the law can only do so much. It does set social norms. And if you are not paying attention to the fact that civil rights laws are being reversed before our very eyes, the Voting Rights Act is being dismantled. The Civil Rights Act of 1964 is being dismantled. Yeah. The educational progress that we made since Brown versus Board of Education is being reversed. All of the social determinants of health that are organized and distributed by law are being reversed, and your vote counts in that matter for you, for your profession, and for your patients. We are at an inflection point. So please don't underestimate how important the law and lawmakers are.
And money has to be appropriated. And I totally agree with you about resources. Title VIII, which funds a lot of the nursing programs and that we have come to rely on, the funds for that title has to be appropriated every year through Congress. So it underscores exactly what Dayna said. You know, I also worked as a health policy fellow with Senator Barbara Mikulski during the time of the Affordable Care Act and saw what good legislation could do to advance the health care of America.
So with that, yes, our voice is very important, and I want to make sure that moving forward, we all, I'm just going to say that all of our voices are important, and we'll leave it at that. Shawn?
Okay. So we have almost 100 questions that have come in, and many of them are around the same theme. One that has been echoed several times is, as a white nurse, what can I do to help my colleagues who are non-white?
And that's a great question. Who wants to have at that one?
I think there are many strategies that white nurses can employ. And one is, first of all, to have a conversation. I can remember when I was deaning at a PWI and I was hiring Black faculty, the white faculty, I actually shunned them, did not welcome them, and was very clear that they didn't want them to be there. So a part of that is to make sure you can have a conversation, a comfortable conversation. It's not always comfortable to talk about race, but to find out how they're doing and how you can help them as they're moving forward. One of the things that institutions have a habit of doing is when you get token Black faculty is to load them up with a lot of service obligations. And white faculty don't have those same obligations. So a part of that is to make sure that the practices, the policies, your hiring practices, that you examine those and then you talk with your colleagues about them. It makes it difficult for them to achieve tenure because they have all of these other things. Talk to them about how to achieve tenure. Invite them to your research projects to be a part of them, those kinds of things. But the most important thing is to just have the conversation about who they are, where they're coming from, and their history to begin to have an understanding of what they are facing when they're on these premises.
Another question I have here is that from one educator, our faculty want to respond to students' demands and our own concerns that we address structural discrimination and disparities in healthcare. However, we seem to view ourselves as being the experts in creating a curriculum that addresses structural racism without acknowledging, I'm sorry, having trouble scrolling here, without acknowledging, much less exploring our own white privilege. I'm curious about how Yale School of Nursing has brought faculty along in their own self-awareness. Anne?
Yeah, and I think I would say it's a process for all of us. And Dr. Beard, I appreciated your acknowledgement that we all have a certain degree of bias, and it's important to interrogate that. And part of what we're doing also is to bring in some trainings, some opportunities to do peer-to-peer work, because I think a lot of this, if we can see examples from our colleagues about how to discuss racism in the way we teach, as opposed to race that is often a fallback, that can be almost more powerful than any workshop that your dean tells you to go to, right? So I think sharing some of those examples, and that's why I hope that as we all try to dig into this in our schools of nursing across the country, that we share effective strategies.
Right. And I think it's important that we understand that we all have different perspectives, and our perspectives come from our different experiences. As healthcare providers, we know good and well, we're not going to do an EKG without having different precordial leads. And why is that? Because without all these different precordial leads, you would miss an infarct. So the same thing, if we don't have different perspectives at the table, we are going to miss the mark on this. We have to be able to be humble enough to hear the voices of other people and respect those voices if we're going to move forward, There's too many times that I'm hearing, and I get it. How would I understand the struggles of someone if I'm not going through those struggles and I don't hear about them? So we have a multitude of problems inside of nursing education when it comes to disparities. We can write a list if everyone chimed in and said what they've seen. When we have faculty who say, you can't come into the classroom 5 minutes late, and we're assuming that everyone drives, that no one is at the mercy of public transportation, and that no matter how early you try to get there, especially now with COVID, an institution saying you can't just come and hang out. People are trying to get to campus in a timely fashion, to find faculty saying you can't come in because you're late. Where is the mercy? We have students who need to use their phones because books are now being delivered electronically. But yet I still hear faculty saying you cannot use technology in the classroom, that you can't use your phone in the classroom. Who will that disenfranchise when we say that? So we've got to think of all the ways, but we won't know them if we don't have people at the table telling us, well, wait a second, who is that policy going to harm? It was a great policy maybe in 1984, but today with the students that we have, that policy is going to harm more than it's going to help. And again, we have to open the doors to have those conversations. Shawn, do you have another question?
Yes, here's one. In terms of the point about the white woman ceiling, I think nursing may be faced with the challenge of being majority white, the oppressor, but also mostly women, an oppressed group. I'm wondering if somebody might speak to the intersectionality as a profession. I believe that men are more likely to advance than women in nursing and be paid more. And that is true. There have been studies showing that men in the same position as women nurses doing the same functions do tend to be paid more. There was a recent research in that in the last few years, as well as that men are more likely in nursing to be executive positions. There's a higher proportion, even though there's only 9 to 10% of men. So would somebody like to take that?
I will, as the only male on the panel. So my first reaction, quite honestly, to that is, how is that possible in a profession where men are not the majority and are not in control in certain areas? Then I would even go push back and say, look, the devil's always in the details. There's a difference between white men in nursing and men of color in nursing. I am an Afro-Latino man in nursing, and I can tell you that I face both racial and gender bias within this profession. Nursing schools have to be really, back to my point about intentional, about how do you address some of these issues. And they have to put resources into realizing they don't have everything in place to help the students that they really are trying to recruit. There's, of all the nursing schools in this country, I think there's a little over 60-something nursing schools that have, associate or assistant deans of diversity that have lived experiences unlike the majority of their faculty. Men coming into the profession of nursing, I think, on one point can only help to elevate it. But even those men who are in nursing positions, if you know that you are in the same position as one of your female colleagues and you are being paid more, you should advocate for your female colleague for pay equity. I know if I was aware of those types of disparities, and when I was also a dean, I became aware of disparities on my faculty that were based on gender. And I took those issues directly to my superiors, and I said, look, here's the only difference is a gender issue. And I showed a blank table to my boss, and he looked across and his eyes went like this. And I said, you see what I see, but what I also see is a potential lawsuit, because the female faculty also know that there's a pay inequity. So back to that point about personal accountability, and we all have to work together. But in the majority, in this profession, where women are the vast majority, and making some of those decisions, there's also some accountability there.
Well said. I think we have time for one more question.
Okay. There's a question here that gets to the heart of things. It says, well, this has been a fabulous discussion and I've learned a lot. How do we start? What can I do?
Great question. How do I start? What can I do? And I keep going back to what Ann did. And Ann, maybe you can walk us through how you developed such a blueprint on anti-racism and was able to publish it on your website that gave your faculty a head start, what it looks like to me, on dismantling racism?
Well, again, really the students, listen to your students. They will certainly tell you what they see about what needs to happen. Have conversations with the faculty. And then I think there's, what I've tried to stress with our approach is that this is the work of everyone. It's not just the BIPOC people in the building. It's the work of everyone. And we have to be able to look at all of the structures and also in the context of our broader university. And Yale is very lucky to have resources. Our School of Nursing is not centrally supported by Yale. We are a self-support school. So we have to be strategic, but we have to try to cross over all of our constituents to get to a more common place with some actual action steps that we now have to follow through on.
Let me add one other thing to this, because I think if we start to examine our curriculum and our textbooks and all the resources that we use, they're all centered around whiteness. And if we can help our students and our faculty to see what that looks like and start to make that kind of change, I think that's sort of basic. Sometimes our faculty don't even recognize it, but students will see it before the faculty will. And so, Anne, I'm glad to hear that you're listening to your students, because that's not always the case. But when they point those things out and to say, that's not my experience that we are talking about in this particular scenario, in this clinical situation, but I have something else to offer, I think that needs to be listened to. But we need to examine that very, very closely. And even in the way we do our exams for our students, what do they really reflect? Is it the experience of everybody or just a privileged few? I think those are some of the questions that we can begin to start this conversation with.
So, Virginia, thank you for amplifying that fact, because it is so important for us to discuss racism in the classroom. And a lot of times that conversation is muted because it's so uncomfortable. But our textbooks are laced with examples of ways that racism gets fostered. We'll say something in the textbook, you'll read something in the textbook that says more Black people are likely to have blah, blah, blah. Hispanics are more likely to have blah, blah, blah. And that's it. There's no context. So no one contextualizes it. No one asks, or I shouldn't say no one because I'm not in your classroom, but sometimes it's difficult to ask that question, why do you think that is? Because sometimes faculty don't know why it is, because they're not well-versed on structural racism. So we need to make sure that we're graduating a group of students that are prepared to dismantle structural racism. They will not be able to do that if we don't have these conversations in the classroom. There is a reason why someone might have a higher risk for hypertension, and it's not based on the color of anyone's skin. That has been a lie that has been perpetuated for many centuries and decades, and we still hear it, we still see it. We know that it's linked to poverty. It is linked to your opportunities. If you do not have a job, or if you are constantly worried or threatened by something, that's going to increase your cortisol level. And with those high levels of cortisol, your blood pressure is going to go up. Period. End of story. So when we don't think about the structures and how they influence health, we do a disservice to our patients, and we do a disservice to the profession. We have to have these conversations in the classroom. Yes, they are difficult, but you can Google search how to do this and get so many hits, you would be overwhelmed. Phone a friend, call someone, ask them to help you walk through this. Let your students know that this is difficult for you, that you've never done this before, and that you might fail, but you need them to help you. And we need to help each other, again, by not shaming. Because if you shame me, you're going to make me less likely to advocate for something. I'm going to fall into a corner and I'm going to go mute. So we need to help each other and support each other, because the journey is going to be difficult. But again, we're nursing. We can do this.
So we're at our close now, and I just can't thank the panel enough for their time and energy and key insights. And just so you all know, there were close to 2,000 people who tuned in on this webinar. For judging from some of the comments in the Q&A box, many people have just said thank you. It was wonderful. I have a lot of questions. We'll try and look at those questions and see if we might get some answers. Certainly, some of the references people have asked for. So I just want to thank everyone again for this discussion. As a reminder,
may I say something before we close?
Sure. Go ahead, Bernadine.
Lacey. And I would like for all of you that are on this call, and I want to thank my colleagues for your wonderful discussions today. But I want to leave you with something. July the 28th, I celebrated my 88th birthday. And I've done a lot of reflection these past few years. So one question I want to ask of all of you, who are you? None of us were born nurses. And nursing certainly has its criteria for who professionals are. But you were born into families. So I want to know, who are you? Because that is going to assist you in working through these racism questions. Just tell me, who are you? That's my comment.
Thank you, Bernadine. And thank you all, everyone on the panel. Thank you for your voice. Dayna, thank you for your legal expertise. Virginia and Bernadine, thank you for your life story and your experiences in helping us recognize where we come from. History is so important. Mary, thank you for everything that you're doing in practice settings to make sure that we're recognizing what racism looks like and implicit bias and how it impacts healthcare outcomes. Sheldon, thank you for everything that you're doing in education and academia and on the boards to, again, go to Congress and say, listen, the story is not over. Let me tell you what needs to be done. And Anne, thank you for jumping out there ahead of this when COVID first came out, putting up this statement in June on your website so a lot of deans can go and see what you've done and what more we can do to make our environments anti-racist. And thank you, Shawn, for allowing us to have this moment because it's so important.
Well, thank you all again. And again, to all the attendees who had questions about references and whether the recording would be available. Yes, we're going to send a copy of the link to the recording will be emailed to everyone who pre-registered. So just make sure your email is in our system. And again, just thank you everyone for a wonderful discussion, and perhaps together it'll inspire some people to get active and we can move the needle forward. So thank you once again all.
Bye, everybody.
Bye-bye.
Shawn, do you